Let me go to the. Could you all see the video? We can't see the video.
The slides, yes.
Dr. Ori, could you see me?
Yeah, I can see you.
Thank you. Good evening. Welcome to the API bi-monthly CME webinar program. I am Dr. Vemuri Murthy, Chairman of the API webinar CME Committee and Program Director. Before we start the program, I request the API President, Dr. Sudhakar Jonlagadda, to welcome the participants. Dr. Jonlagadda, please.
Good evening. Thank you, Dr. Vemuri Murthy, for arranging outstanding CMEs for our members. It's going so good so far, and this year we made remarkable progress in an academic way of API, which is my main goal, and I'm hoping we are reaching the target. And we have a great speaker today, and apart from that, next week, please stay tuned that we're going to have a CDC going to speak on COVID-19 updates of global epidemiology and testing and vaccinations. Please stay tuned next Wednesday. And also, this year we started doing a community outreach program once a month. We are using a media, ZTV, and we already did one with lung cancer in month of November. In the month of December, last week of December 27th, we're going to do on cardiac diseases, particularly in the Asian population. And thank you again, and all your support. Go ahead, Dr. Murthy.
Thank you, Dr. Jonlagadda. Today's topic, advances in oncology, has been approved by the Chicago Medical Society for 1 hour of Category 1 AMA CME credit. So please use the chat line for question and answer session. The moderator will select questions for 15 minutes of the session, and please submit the pre and post surveys to claim your credits. Today's program moderator is Dr. Savita Balraman, who is a medical oncologist with excellent credentials. She is with Michigan Healthcare Professionals PC in Royal Oak, Michigan. Welcome, Dr. Balraman.
Thank you.
Now my pleasure and privilege to introduce our distinguished speaker, Dr. Nori Dattatreyu. Dr. Nori is Professor and Chairman of Radiation Oncology at New York Presbyterian Cornell Medical Center and Director of the Cancer Center at New York Presbyterian Hospital, Queens, for the past 25 years. I'm going to be very, very brief because I can keep on going for about him. He published 250 peer-reviewed articles and authored 3 books on oncology. The various honors Dr. Nori received nationally and internationally include the Padma Shri Award from the Government of India for his outstanding contributions to the field of oncology, Tribute to Life Award from the American Cancer Society, and the Living Legend in Oncology Award from the Indian Society of Oncology. We welcome you, Dr. Dattatreyu Nori. Thank you.
Thank you, Dr. Murthy. Thank you, Sudhakar Garu. And thank you, Savita, for being the moderator. Good evening, everyone. Time is 8 o'clock here on East Coast and 5 on West Coast. But I will try to make this interesting. Everyone, oncologists and non-oncologists. Advances in oncology. What are some of the advances we have seen in the cancer field? This will be interesting and very important for everyone. This slide shows some important information, piece of information. If you look at the left side, global cancer cases by 2035, which is about 15 years from now, will be reaching 24 million. And then the death rate will go up from about 9 million to 15 million. On the other side, you see the cost of care for cancer. It will go from 290 billion in 10 years to almost 450 or 60 billion. All this is going to impact developing and developed countries like India. So we had to be prepared not only to cope up with this almost what we call tsunami of cancer, not only that, but also the expenditure we had to be prepared unless we come up with some interesting or innovative techniques that can cure even advanced cancers. That's what I'm going to share with you. Evolving paradigms. The discussion will be under three main headings: evolving paradigms, new discoveries in cancer, advances in clinical oncology. Advances in clinical oncology. Those non-oncologists in the group listening now, in our medical schools post-graduation, we have seen, when you talk about cancer, your surgeon, surgical oncologist, or your pathologist say there are predictors of outcome. Primary predictors is size, pathology, and grade, simple ones. We read that in our medical school. We moved from that to secondary predictors like tumor markers, ploid, and receptors. Now, in the current generation, we look at the gene expression, EGFR receptor expression, molecular and proteomic profiling. So we are understanding better the molecular underpinning of cancer. So we'll be able to intervene not only to treat, but even to prevent certain cancers. This is an interesting, even though it looks complicated, it's not really complicated. What we thought for many decades is what you see. I'm sure you can see my marker on this screen, Dr. Vimori. Okay. We thought radiation, by giving radiation or chemotherapy, we are attacking the DNA of the cancer cell. A very simplistic understanding of how these treatments work. We didn't know that the development of cancer, proliferation of cancer, metastasis of the cancer is not coming from here, but from the cell membrane, what you see here, the shield here. So what we identified, there are three levels of receptors that are pumping signals to the nucleus in the center. One is the extracellular domain, you see that? The other one is transmembrane, cell membrane receptors. The third one is intracellular receptors. Three levels of insults the cell is getting to become cancer cell. So by just destroying this will not be adequate. What we learned over the last 15 years is how can we block these receptors coming from outside the membrane, transmembrane, and inside the cell membrane. So this is what we call, we are running now, getting into targeted therapy. We identified targets on the cell surface. On the cell surface, these are targets external, membrane, and internal. If we can block one signal going to the center of the nucleus, we can cure that particular cancer. You see here how many targets are there all around the cell membrane? And we have identified, and Dr. Savita knows, identified different drugs, targeted drugs, to block these signals coming to the center of the nucleus. By blocking one, we have blocked the proliferation and improved the cure rate. These are cure rates, not control rates. Example here. Here is, look at the Gleevec. Where is the Gleevec here? Gleevec here. A Gleevec is a tyrosine kinase inhibitor. By giving this oral pill, blocking this signal, the CML, chronic myelogenous leukemia, taking one pill a day is cured. At 5 years, it may recur, but we have second generation drugs, but it can be cured. That shows how the targeted therapy can work by blocking the signal. Say I go through around the cycle, what I call is a hub and spike cycle here. Tarceva for lung cancer, and Erbitux for head and neck cancer, Avastin for colorectal cancer, and Herceptin for breast cancer. Improved the outcome by 30% here. Cure of CML, rituximab in lymphomas. Look at all these drugs. All these drugs and more second generation drugs are also coming into play. Now, some of them even third generation drugs, basically trying to block the signal and decrease proliferation of the cells, cancer cells. What we see from a glance, what you see here, each drug is working on one target. This one, rituximab on lymphomas, Gleevec on CML, Herceptin on breast cancer, Avastin on colorectal cancer, and so on and so forth. One drug, one marker, one receptor. But how can that's not, if you want to attack all these receptors at the same time, how do we do that? Because you don't want to take 10 drugs. That is the next level of evolution of treatment is the immunotherapy. Immunotherapy works on all the targets. It's not like cytotoxic chemotherapy killing the cancer cell. Immunotherapy enhances the immunity in the body to attack the cancer cell. So the function of immunotherapy is slightly different than chemotherapy and radiation. That's very important. So to take home point here is across the board, if you want to see a treatment that works on all receptors, is the immunotherapy. So let's check the discoveries. I just put them in one slide. The targeted therapies, Herceptin breast cancer has improved the outcome. Avastin for advanced lung cancer, ovary cancer, and colon cancer significantly improved the outcome. Rituximab for T-cell lymphomas improved the outcome significantly. Erbitux in head and neck cancer improved. Tarceva for lung cancer, stage 4 lung cancer, Tarceva. I'm sure Kavita has treated many patients. Stage 4 lung cancer with taking the Tarceva pill every day, you can give them 5-year remission, even more than 5-year remission. Single oral pill. Gleevec for CML, well cared for multiple myeloma. So I mentioned to you the evolution of our treatment with the targeted therapies. Now the new generation is this immunomodulation, is a new frontier in cancer treatment. Pharmaceutical companies, academic centers are spending billions of dollars on this because there is something there. There is a real proof that it will work, and it is working. I'll show you some classical examples of what it does. And what happens is, as a radiation oncologist, why am I so interested in immunotherapy? Because we have shown from our lab studies, from clinical studies at Cornell, that combining radiation and immunotherapy, they work together best, because what immunotherapy needs is the targets, and radiation produces more targets to attack for the immunotherapy to work. So there is a synergistic effect between radiation, and there is no controversy about that anymore. People across the world are using radiation along with immunotherapy. So what is happening in immunotherapy is like this. As the tumor develops in the body, it knocks down our command and control system, which is our immunological status. It just knocks it down. Otherwise, it will not be functional. Our immunity won't work for our tumor or infection. So there are two types of nasty substances these cancer cells are producing. One is called CTLA, the cytotoxic T-cell lymphoma-associated protein or antigen. This is one. For non-oncologists, just remember, the cancer at the present understanding is producing two antigens or nasty cells. Called, one is CTLA. The second one is PD-L1, programmed cell death protein 1. Two nasty substances that are destroying our command and control center in the body, that immunity is down completely, so the tumor can grow back. So what is now happening is we have identified the drugs that can release the brakes on these two antigens in the body, release the brakes. Release what I also call breakthrough the molecular shield produced by cancer to enhance our immunity. So these drugs are called, brake-releasing drugs are called the checkpoint inhibitors. So two nasty substances. There are many drugs in the pipeline to get our immunity back in the body. So there's one more concept. I will mention that, and then we'll move to the next question. As what is the role of radiation here? Why am I saying so much about immunological stimulation and radiation? As radiation is given to one area, for example, if a patient comes to you with metastatic disease, lung cancer going to brain, liver, bone, soft tissue, if you radiate one area of the body, soft tissue or liver, it produces activated T lymphocytes. These are attacking soldiers. And that will also help the immunological drugs or checkpoint inhibitors are immunomodulated drugs, much better. What is this complicated slide showing? What it's showing is, as you give radiation to a small area in the body and combine that with immunotherapy, there is what is called, just remember the definition, abscopal effect. What is abscopal effect? In a metastatic setting, if I radiate a small area and put them on immunotherapy drugs, there is a systemic effect of this radiation. That means the T cells will go everywhere in the body and have a chance to knock the cells down, cancer cells down, either in the brain or in the bone or in the soft tissue. This is called abscopal effect, which we have published about this many, many decades ago. Now we are seeing in more and more number of patients with immunotherapy, abscopal effect. Just remember that. This example, next one, will give you a clear understanding for all the clinicians here, oncologists or non-oncologists. Just this one, a patient of mine treated by one of my researchers in the hospital. Look at on this side here, patient has lung cancer, went to liver, see the liver nodule here, and to the other opposite side here, and with a presacral mass. Everybody appreciate that? Just raise your hand if you see that, what I said. Okay. A metastatic, widely metastatic lesion. We treated him with a short course of radiation, Kavita, to only liver, a very short 1 week of radiation with SPRT to the, and put him on this immunomodulator drug, ipilimumab, which everybody knows, most of the oncologists know that this is an immunomodulator drug. And then radiated only one area, not all areas in the body. The other side, you see here, the liver nodule has disappeared, which got radiation and immunotherapy. The lung area has disappeared. And they look at the presacral, pre-treatment and post-treatment immunotherapy. The presacral nodule disappeared. We have never seen this kind of dramatic responses in metastatic cancers. And this patient is alive at 5.5 years, disease-free. Kavitaji, this is disease-free. So this is the type of results we are seeing when you combine a modest dose of radiation immunomodulation drugs. So as she knows, and all the oncologists know in the group, in the setting of metastatic, widely metastatic lung cancer, non-small cell lung cancer, the cure rate has, 5-year cure rate has jumped from 5% to 20% with this immunomodulation drugs. Look at the quantum leap there, 5% to 20%. And now the immunotherapy has come to the front line. There are a number of studies published in New England Journal of Medicine, our own studies, showing, forget about chemotherapy, immunotherapy can do the job even in metastatic cancer. So that, why am I so excited about this, is immunotherapy works better if the mutational burden of cancers are very high. Mutational burden, what is the definition of mutational burden? In simplistic terms, I will define that as how nasty the cancer is. There's higher the mutation burden, higher is the response to immunotherapy. Why am I so excited about immunotherapy for India? Most of the cancers we see in India have highest mitotic index or mutational burden. So there is a chance when we use these drugs, they're already using it, the responses will be much better than what we see in American patients. This is a case in point. I'm sure everybody recognizes him. He has a melanoma. So the immunotherapy works much better for about 5-6 cancers, dramatic response. He has melanoma in 2015, February 2015. Melanoma spread to liver, brain, and bone, 3 areas. We radiated the liver with a small, not we, he didn't come to us, but in Atlanta. Liver received radiation only for a week, modest dose of radiation with stereotactic radiotherapy, and put him on the drug Keytruda, Pembro, what we call Pembro, is a PD-L1 inhibitor, Keytruda. Now, he just broke his bone because of old age, elderly age. but he is free of disease now. It's close to by January next month, it will be 6 years since his treatment completed with the metastatic disease. So these are some of the most gratifying examples we are seeing in oncology. Who are these two people? I'm sure everybody recognizes them. There are two Nobel Prize winners in 2018. One is a Japanese guy, one is from New York, went to MD Anderson, James Allison. Why I'm showing two? If you remember in the beginning, I mentioned two nasty substances the cancer produces, two antigens, CTLA and PDL1. One discovered CTLA, the other one discovered PDL1. So those two substances, the antigens they discovered, each one got a Nobel Prize for that one. And there are so many reports in our literature and also in the media that very aggressive cancer. There is a report in New York Times last a couple of months ago about 4 patients with advanced ovarian cancer, have high mutational burden and all that. And no treatment worked. They have exhausted every treatment, finally went on immunotherapy. They were disease free at 4.5, 5 years. These are most gratifying examples we are seeing. So we moved from targeted therapy with all the circle I showed you, cycle, and then immunotherapy, immunomodulation. The next one, the level up is equally important, is the precision medicine. What is precision medicine? Precision medicine is like your, if I want to make it simple, for any infection, you do antibiotic assay. Which antibiotic works better on that particular patient? The same thing here. What is the genomic study? Cancer Genome Atlas started in 2003, and it actually started in 1990, then produced first report in 2003, and then subsequent report. What this has shown, very important, not only is this is like a genetic makeup of how we as human beings, how many genes we have, how many variations we have. This is a very important contribution of genome studies for medicine. And what this has shown is what I show you in the next slide. That is, when you analyze the cancer genomes or the general, non-cancer, there are 3.2 billion bases, we call them bases. Roughly 99% are identical to two individuals. Between me and the next person, 99% we are identical. But what makes you who you are and the next person who he is that 1% variation in the genomic makeup that makes you unique. So that 1% tells you, or at least gives you an indication at what time frame you will get a cancer, at what type of drugs will work for you, what type of drugs will produce severe complications. So this is all hidden in that 1% of the genomic makeup of individuals. So that is very important information from the genomic analysis. I'll put that in a simple understanding way. Take, for example, a lung cancer patient or a non-small cell lung cancer patient. This is before our understanding of precision medicine. Take, for example, these guys here in the slides. Everybody looks the same. So what we did in the past, 15 years ago, put them on, if they have particular stage, put them on a standard chemotherapy, same regimen to everyone. Same regimen to everyone because they also have the same stage. But what happened is this. That is, some of them responded, some of them did not respond. Why is that? The same stage, same age group, same histology, same pathology, but some of them did not respond. We didn't understand before this genomic analysis is done. Now we understand, look at this one. This is where that 1% genomic makeup makes a difference. This is, look at this. In some, this is the central group here, complex group. In some, the drugs we were using were toxic and beneficial. In some, the drugs were toxic and not beneficial because of that 1%. And some drug not toxic, not beneficial. And here is the good group here. The drug not toxic but beneficial. So what have we been doing all these years is giving one mantra to everyone. It cannot happen. because the molecular wise, profiling wise, this group is totally heterogeneous, very complex. So now we are understanding through this which group really gets benefit from the drugs. This is called precision medicine. So we have taken you, I have taken you to targeted therapy, immunomodulation, precision medicine. Now let's see how much time we have. Okay. There is another thing for a little more people, the people or doctors who are into research, so as most of you, some other things have come to our knowledge here. Cancer evolution constrained by mutation order. That is, analysis of the cancer depends parallels between ecological evolution and tumor evolution. What I mean by this is, I'll show you this is, next slide is much better. Yeah, I told you that 1% determines a patient at what age he will develop a cancer, because you can study the genomic profile and the chromosomal depletion. You know, Philadelphia chromosome, you heard about leukemias. Here, you can study patients, any individual, the deletion of particular chromosome and tell this guy, clear cell carcinoma, you will get clear cell carcinoma at age 50. And this is the particular drug that is going to help you. So these things we can now tell them. Even the mutation profiles of HPV positive, HPV negative tumors are different. The understanding has increased significantly. So this is another step forward. What everybody is doing, these studies, Foundation 1 testing, gives you the tumor profile, molecular profile, and tells us, the doctors, treating doctors, which drug will work, which drug will not work in a particular individual. Now let's take you to the advances in clinical oncology. How much time we spend? About 30, 25 minutes. Huh? Okay, how much time I have, Murthy, Dr. Murthy?
In about 10 minutes.
Okay, I'll make it. All right. So advances in clinical oncology. I'll share with you, because I showed you chemotherapy, which is targeted therapy, precision medicine, and all that. Let's go into a little more radiation oncology. You have seen in everybody working in hospital, when you hear about radiation, you have seen a technological explosion of different technology. All this, cyberknife, tomotherapy, arc therapy, all these are all technological advances we have seen in the last 15 years, each one trying to be more precise, and the dose of radiation to be exquisitely precise. That's our aim, to deliver radiation. So for example, this patient, now we can show in a cloud display the tumor and normal tissue, identify the tumor, and hit this tumor with extremely exquisite precision with what we call stereotactic radiotherapy, with just treating the area here without touching any of the normal lung or the spinal cord. And this is one example of stereotactic radiotherapy for a lung lesion. Here, you see here, and this is at 2 years and at 5 years. Response is extremely good with stereotactic radiation. This stereotactic radiation is like a pencil beam radiation. We started using it in stage 1 inoperable lung cancer patients. The results were so outstanding. Now we are using that even in operable lung cancer patients, which has become standard of care. This is only 5 treatments in a week. 1 week, treatment is gone, and what you see, this kind of result you can obtain. So this is all technological and technical advances in radiation oncology. There is one more thing that happened in last 10 years, the game changer, that is proton therapy in radiation. Proton therapy in radiation is a very huge investment. A lot of major centers now trying to acquire that. Even in India, I inaugurated the first proton center in South Asia at Chennai, by Apollo Hospital. Actually, this slide is from Apollo Hospital. And what is the great advantage of this? Why I'm even showing this slide is this is standard radiation. All the machines I showed you in that slide. Produce entry, there is radiation going into the body. The radiation has to exit through and through on the other side of the body. Whereas with proton radiation, the radiation enters and only stops at the tumor level. No exit. So it's a very precise deposition of energy only to the tumor. That's the reason this is a very expensive machine, and it is available in most centers. And we use that in pediatric cancers, in central nervous system tumors, brain tumors, and any tumor that is adjacent to a vital structure, we use this technology. And I will go very fast now in under 9 minutes. I will not show all this except this one, breast cancer. You see here the latest gentler treatment. This is where we are working on gentlest treatment. That is, mastectomy is standard of care many, many decades ago. Now lumpectomy and radiation is equally important, equally good treatment. But radiation required 5 to 6 weeks of visits to the radiation department. So what we have done in advancing the methodology how we deliver radiation is the standard of care is 6 weeks of radiation with IMRT. We condensed that to APBI, 3 weeks. Tell Frank, this is one of his contributions, Frank, from your place.
Yes, I'm very aware. We participated in the study, Dr. Nouri.
Yeah. And brachytherapy is my contribution to make the treatment to 1 week, from 6 weeks to 1 week. And now we have treated close to 2,000 patients with intraoperative radiation. That is, take out the lump, give 1 shot of radiation with a special beam, and that's a 1-day treatment. Everything is done, patient goes home, no more, unless the patient requires chemo, she comes back after 1 month. So we have simplified the treatment, make it more easy for our patients to accept, 6 weeks to 1 day. Then the same type of treatments we have done in prostate cancer also. I'll show you this slide. In prostate cancer also, we have made the treatment, robotic prostatectomy is equally good along with radiation or with radiation alone. So what this is showing, this slide, is this is the prostate, this is the rectum, this is a transrectal MRI of the prostate. And if you do surgery on these patients, you take out the prostate and the neurovascular bundle, which controls your erection and ejaculation, lies here on both corners, on this corner and this corner. So invariably, they had to sacrifice that if there is a tumor involved. Whereas with some of the techniques we have designed for external radiation and brachytherapy, we can save the neurovascular bundle and give them equally good outcome in terms of cure rate with the least chance of erectile dysfunction with radiation. So that's one of the reasons why people look for more non-surgical options. Not that robotic surgery is not bad. In experienced hands, it is equally good. And I'll show you one example of this gentleman here. He has prostate cancer, one of my patients. I don't have to tell him. He's on the TV regularly on every channel. Our mayor, Giuliani, before, he has prostate cancer. He's now 17 years post-treatment. Where he has, like other prostate cancer patients, deciding on the treatment, Giuliani had to weigh both the medical and personal factors. In choosing to have a radioactive pellet implanted in his prostate, he selected an effective treatment with far fewer side effects than surgery. So this is came out in New York Times. So I will not tell me when to stop. I'll just show a couple of examples. Dr.
No, please go ahead. We will extend by 5 minutes because we lost 5 minutes initially. Please, 5 to 7 minutes. Thank you.
Okay. So we have introduced some innovative technology at Sloan Kettering for patients who are resectable, but in the intraoperative setting, you find the tumor stuck to either spinal cord or major vessels or chest wall. What do? You close and give them palliative radiation. So this is where we have developed very innovative techniques here. You see here the tumor, superior sulcus tumor, the vertebral body destruction here, and we resected that and placed some intraoperative implants with the radiation. These catheters deliver radiation in 3 to 4 days, and we remove the catheters. And then this is the lesion. Another patient, came with the superior sulcus tumor, pancreas tumor here. We resected the tumor, margins are positive, and we did this type of plaque therapy, what we call take micro pellets, take them in a gel foam and vicryl mesh, and prepare like a plaque and place it in the area of the surgical defect where the margins are positive, intraoperative. So we are converting a positive margin into a negative margin right there intraoperative. You don't need anything postoperative. So this technique was published and developed by us at Sloan Kettering and now used all over the world actually, in all the US hospitals. So why I'm making a big deal about this technique? This technique, we published this some time ago, is the reason here. Everybody can identify who this is. Our past president, Neelam Sanjeev Reddy. He was diagnosed with a coin lesion at All India Institute of Medical Sciences. And he came to us at Memorial, and the lesion was resected, but margins are positive. And you cannot do a lobectomy or pneumonectomy on him because he has severe COPD. He has severe COPD. He cannot do that. So then we used this innovative technique. He survived 18 years following the treatment with positive margins, but treated with intraoperative radiation. And he did well. He died of non-oncological problems. And then I will show you this one example, then we'll close. This is a patient, a 25-year-old patient with fibrosarcoma here. Kavita can see this fibrosarcoma, treated multiple times surgically, multiple radiation treatments, and he went to Mass General. They recommended him to go undergo 4-quarter amputation. That's the only treatment they can offer because he was heavily treated before with radiation and multiple surgeries. So we used this innovative technology we developed, taking out the lesion here and putting a myocutaneous flap on that and delivering intraoperative radiation with the catheters in 3 to 4 days in perioperative. And this gentleman now is like this, see here. So these techniques we have developed, they're serving two functions. One is limb preservation and function preservation. It's not enough if you just preserve the limb and the guy cannot use the limb. So function preservation, limb preservation techniques are some of the innovations we have done, are used now throughout the world in major hospitals. I think I will stop at that point. The last slide here is what we have seen over the last 35 minutes is evolution of technology, technique, and innovation. We started with surgery, still a standard of care, radiotherapy standard of care, cytotoxic chemotherapy standard of care, precision therapy. I give you several examples of precision therapy. Now immunotherapy is one of the pillars of oncology. And this is a slide. American Association of Cancer Research, AACR, produces innovations in the field every 2 years. This is so they put it on the map. That means it is going to be here for forever, immunotherapy. So last slide, conclusion is progress in cancer treatment will certainly increasingly utilize individualized treatment strategies. Modern pathological characterization will determine which tumors respond best to what type of treatment. Targeted therapies with the drugs aim at EGFR receptors. Immunomodulation treatment, either alone or in combination with radiation, will enhance the outcomes of majority of advanced cancers. We know how to treat early cancer, but advanced cancer. Thank you very much.
Thank you, Dr. Nori. What can I say? It is a very crystal clear presentation. And thank you for accommodating the non-oncologists like myself, And this is really, truly, truly amazing. Thank you for that. So at this point, I request our moderator, Dr. Balraman, to take over. And you got 15 more minutes. And I know a lot of people have lots of questions, And again, thank you, for giving such an outstanding presentation.
Thank you again, Dr. Nori, and everybody in the audience. And thank you, Dr. Murthy. So there is an interesting spectrum of questions that have come, I think, mostly from non-oncologists. The first question was about the role of diet in oncogenesis and in immunotherapy. Dr. Nori. Specifically, they were asking about dietary immunoboosters as well as dysregulation of the immune system because of diet, role of curcumin, cinnamon, etc.
Very good. Good question. Whoever asked it, very good question. When I'm talking about immunomodulation, I did not mention about one concept, but what is it? Immunological set point. Set point. This published in Nature last year. That means the balance of immunity in the body, when it is going to tilt, is going to be down. There are two factors for that. One is intrinsic, the other one is extrinsic. Intrinsic is some genetic makeup, we can do something, we cannot do something. But extrinsic factors comes in the diet. The extrinsic factor is diet, the microbiota in the intestine, all this play a role in the viral infections, the infections, how you keep your body from all kinds of toxins is important for maintaining the immunological balance. So all these antioxidants you mentioned about our Indian and other turmeric and others, there are certain published data, but as we all know as scientists, we had to see a prospective randomized trial. We don't believe anything. But anecdotally, they seem to work to improve the immunological balance. But there is no level 1 evidence to show that.
I 100% agree. And I would also, I think, allude to the article that was published in Journal of National Cancer Institute, the JNCI spectrum. I think within the last year, there was a study from the Tufts group that talked about the 7 dietary risk factors, including low grain intake, high processed food intake, attributed about 40% of the cancers in the age group between 40 and 50 to poor dietary habits. So that's a wonderful article for all of us to read for ourselves, for our patients, and for our family. And integrative medicine has become a very important part of oncology. The next question specifically was about pancreatic cancer, treatment options today in pancreatic cancer. Dr. Nori.
Good. Pancreatic cancer, resectable cases have to undergo surgery, Whipple's procedure, no doubt about it. What MGH, Harvard has published, even if the margins are negative after Whipple's procedure, the chances of local failure in excess of 50%. So those are the group of patients you need to consider post-operative chemotherapy, gemcitabine, and radiation. For unresectable cancers, again, I showed you that lung cancer example, 5 years ago, stereotactic radiotherapy is coming to the front line along with chemotherapy. So we do have a lot of studies done. Published data do suggest that this condensed, intense radiation stereotactic beam is giving them excellent outcome in terms of palliation, and there are good number of long-term survivors at 2 years and 2.5 years. But still, it's a bad cancer.
And now with the advent of neoadjuvant FOLFIRINOX, which is a quite well-tolerated chemotherapy as opposed to what we thought was going to be the side effect profile, I think more patients are living longer. And as you mentioned, we're also treating it with immunotherapy for MSI-high pancreatic cancers that are metastatic. That again goes to show how significant the progress has been within the last year and a half to 2 with immunotherapy. There was a question about gene modulation as a mechanism for prevention of cancer as well as treatment of cancer, in addition to radical surgery, chemo, radiation, and immune therapy.
Immune modulation?
Genetic modulation, yes.
Gene modulation, that is going to be coming very soon. As I mentioned to you, with this genomic analysis or molecular underpinning of cancer, if we can identify the chromosomal abnormalities early on, before it goes to 5, 6 steps, if we can identify that the gene modulation at step 1, for those patients, we can prevent getting a full-blown cancer. These things are happening. And, in breast cancer, as you know, the BRCA and the B positive, we do give them preventive strategies for not getting breast cancer.
I also think it's not just about the genetics, but also CRISPR technology, right? Modulation using CRISPR technology, Dr. Nori will, in the next few months to years, I think we're going to see a lot more with CRISPR technology as a mechanism of modulation of oncology cell lines.
Yeah.
There was a comment about staying lean, active lifestyle, quitting smoking, and moderate drinking may take us away from expensive treatments. Your thoughts on that, Dr. Nori?
Yeah, moderate drinking. First thing is smoking is not. There is no moderate smoking, unfortunately. Drinking in moderation, just again, the antioxidants may play a role. Anything in moderation, as oncologist, you advise and I advise the same.
And I also want everybody to remember
diet,
drinking.
Yes.
Sorry, Dr. Nori.
Diet, high fiber diet, low fat diet will certainly help in breast cancer, in prostate cancer, in ovarian cancer, and endometrial cancer.
Also, I just wanted to remind everybody in the audience, moderate drinking is different for males versus females because females metabolize alcohol. And that's actually one of the risk factors for breast cancer. So we want to remember that when we advise our patients. There's another very good question. Dr. Nori, what are the limitations of proton therapy other than the cost?
You already mentioned about cost. It's expensive. But in the US, it is covered by Medicare. It is covered if the indication is there. In India, it is still very expensive because there is only one center providing this care. The advantage of proton therapy is if the tumor is attached to a vital structure. I'll give you either the question when is it indicated or what was the question?
What are the limitations other than cost?
Other than indication, other than cost.
Limitations.
Limitations are if there is a deep-seated tumor, which is not, I showed you the radiation has to be deposited around the tumor. If you had to go through several important critical structures, it's not useful, number one. Number two, because there is an intense deposition of energy, radiation energy with proton, anything that the vessels are exposed post-operative, that means if you do a radical Whipple's procedure, I have one example, I refer to Chennai. Patient has an excellent surgical procedure, but the vessels are all de-skeletonized. Then you have to be very careful because the dose is so intense that the vessel cannot tolerate. So any oncologist treating with proton, they know these limitations. But in general, it is very useful. If I may give you an example, I saw a patient in India, 40-year-old, with, they diagnosed that as mesothelioma, fibrosarcomatous mesothelioma. And all kinds of conventional chemo, including immunotherapy, did not work for 2 years, and still local isolation. And I brought her here to New York. We operated on her, removed the lesion, removed part of the ribs, removed the diaphragm, and reconstructed everything. This patient is an ideal case for proton therapy because we know the delineation of the target.
Okay. The next question actually also pertains to proton therapy as it relates to one, glioblastoma, because you did mention about CNS tumors. They want you to compare and contrast proton therapy to conventional radiation, Dr. Nori.
Yeah. For glioblastoma, as we all know, it's a very grave disease. It's still, we don't have an upper hand on that. Proton therapy is used only as a boost. after primary radiation, not as a full dose radiation. And proton therapy is routinely used for recurrent glioblastoma, but not as a primary treatment of frontline yet.
And what about in breast cancer, the role of proton therapy?
The role of breast cancer, the proton therapy in breast cancer, we have not been able to show any additional benefit in breast cancer. We have shown a benefit in prostate cancer, in lung cancer, in head and neck cancer, but not in breast cancer because the conventional treatment results are really outstanding for breast cancer.
Dr. Nori, you did allude to stereotactic body radiation therapy extensively. The role of whole brain radiation versus gamma knife in brain metastases, and what do you see as a radiation oncologist being the #1 advantage?
Good question, good question. If you have brain metastasis, somebody has brain metastasis, would you consider giving whole brain radiation or the gamma knife or stereotactic, a focal radiation? The trend now, standard of care in oncology, radiation oncology, is to give focal radiation, not the whole brain radiation, because these patients do come with other lesions. So you need to spare the brain, the cognitive function of the whatever number of months or years they survive. So it is now giving only spot radiation with gamma knife or stereotactic radiation.
And I have had some patients, Dr. Nori, personally, like other oncologists, who have had 5, 7, 10 different treatments of gamma knife during the entire course of their disease, but they don't go on to develop the ataxia, the dementia, the loss of fine motor skills. It was actually a hallmark of whole brain radiation when we used to treat the patients with whole brain radiation.
Exactly, yes.
The next question was about ovarian cancer detection. What is your thought and recommendation about routine pelvic ultrasounds in early detection of ovarian cancer?
Very good question, close to my heart, because there are a number of tests available for most of the cancers we know: breast cancer, mammogram, lung cancer, CT scan, screening. But there's one cancer that is hidden that you will not be able to diagnose until it is stage 3 or 4. This is ovarian cancer. So if at some point, if we can develop a, what do you call, a protocol or best practices, include in our routine annual examination. That's what I'm pushing in India. Routine annual examination. Ultrasound won't cost more than 1,500 rupees in India. Why don't you go for? Because if you diagnose, if you're stage 2, we can still cure them. So I am certainly in favor of, if somebody is going for ultrasound, you are spending every penny worth of it.
Unfortunately, the current recommendations are suggestive of an ultrasound for people with genetic mutations, but you're right, there's never been a randomized study, and in the US, we're limited by what is exact science.
That's right. But the cost, luckily it's ultrasound, it's not big. It's not like MRI or CT scan. Sometimes you do transvaginal ultrasound, you can detect a mass, solid or cystic.
And Dr. Murthy, how many minutes do I have?
Well, you got time for one question, okay, because I got the privileges of asking the last question.
So this will be my last.
I thought it is Sudhakar.
Sudhakar will ask after the presentation.
The last question.
Please go ahead, Dr. Savita.
Is about the effect of yoga and meditation in preventing cancer and in the cancer treatment journey.
Yeah, I won't say anything about prevention of cancer, but it complements cancer treatment. People who are on yoga and all these, they go through chemotherapy, radiation much better than people who are, who are type A personalities. So there is there is proof that it helps. It complements the standard of care treatment.
And I think the University of Pittsburgh group actually published a very provocative study with radiation and the side effects, including incontinence. This was external beam radiation, incontinence, fatigue, etc., and showed that there was a potential suggestion for benefit in the yoga group.
Exactly what I say, compliments. Yeah.
Yes. With that, I turn the floor back to Dr. Murthy and Dr. Jannalagada.
Yeah, thank you so much. Dr. Nori, just one last question, what is the future of onco vaccines?
Future of onco vaccines will certainly help. They're already here. They're already here. You have a hepatitis vaccine, very useful in India. And you have cervical cancer vaccine, Gardasil is working very well in Europe, India, America also. So there are already certain vaccines we know are working. So there will be more and more, as Kavita pointed out, in the preventative aspect of cancer, it will be useful.
Yeah, thanks a lot, Dr. Nori. Thank you. I think, could you see me?
Yeah. Okay.
Okay, I lost him. I lost the connection, but as long as you can hear me and see me, So at this point, I request our President, Dr. Jannalagada, to honor Dr. Nori. Dr. Jannalagada, please.
Yeah. Thank you. Thank you very much, Dr. Nori. What an excellent presentation. First of all, I want to thank your moderator, Dr. Savita Balaraman. Fantastic moderation, Savita. You did an excellent job. Members should know that, Dr. Balaraman is our current chair for research of API committee. I'm sure you are going to see more and more research protocol coming out through their committee. And I'm sure, and I'm so proud, API moving to a right direction of academics. Okay. Thank you very much, Savita, for moderation today. Dr. Nori, as a non-oncologist, I learned 3 things today. Number 1, the survival is going to get better. Number 1. Number 2, I learned about immunotherapy, serotac radiation, and proton therapy. Okay. If I can know this, everybody should know this, because thank you again for the excellent talk. And thank you, Dr. Murthy, for arranging some excellent CME today. Ms. Kodali, can you put the slide on, please? Thank you. Dr. Nori, it's my honor to recognize Dr. Dattatreya Nori, MD, for his outstanding contribution to radiation oncology, and welcomes him as a member of API Distinguished Speakers Club. Sudhakar Jannalagada, President, National API, and Dr. Vemur Murthy, Chairman, API Webinar CME Committee, December 9th, 2020, Oak Brook, Illinois, USA. Thank you again.
Thank you. Thank you. Thank you, Sudhakar. Thank you, Murthy.
Thank you very much.
I really enjoyed the questions. This is very good. Kavita, thank you.
Thank you, Dr. Nori.
All right. Stay safe. Good night.
Good night. Good night.